All right, well, welcome to our 3 o'clock session here. Today I'm lucky enough to sit up here with a panel of experts to talk about data-driven route to healthier outcomes. And so I am Michael Moody. I'm the Senior Vice President of Customer Success for CAQH. I've only been with the company about 6 months now, but prior to this, I spent about 30 years working for a company that ran hospitals. It was a post-acute company, and so I spent a lot of time in the healthcare industry. And so this is near and dear to my heart, not just one professionally as someone who spent a lot of time in this part of the industry, but also just as a patient and consumer. So I'm going to let the panel introduce themselves, and Don, I'll start with you. I'll let you go ahead first.
Yep. Hi, thanks everybody. Don Rucker. I'm with a company called One Up Health. So we provide the CMS required FHIR APIs for cloud data that payers are required to do. And we'll talk a little bit here about going from not just to patients, which is the current reg, but out to providers and to other payers. And what's interesting about that business is when you have these data stores in the cloud, you can actually do vast amounts of highly efficient real-time computing on those data stores. So it gives you a very different paradigm than what you've historically done, hanging an EDW off sort of a claims pipeline. So anyway, One Up Health.
Mona Siddiqui. So I lead home and community care for Highmark. And Highmark, for those of you who may not know, is an insurance company, but we also own about 14 hospitals and have either partnerships or equity in a few other health systems as well. So I lead community care, which means think home health, hospice, palliative services. We have a DME business, a home infusion business, and we have a joint venture where we focus on shifting volume from hospitals to a hospital at home program, as well as SNF at home. So while I'm not working directly with the data anymore, obviously a lot of the information that we need to be able to say who's appropriate for what kind of services and getting the right care at the right time for that patient relies on that partnership and making sure that we have the right information. So looking forward to the conversation today.
Great. Can you hear me? Rohan Trusagar. I lead the analytics and AI teams at a company called Somatis. Somatis was the first, one of the largest specialty value-based care companies focused on complex chronic kidney disease and cardiovascular disease. And we get a lot of data. We have longitudinal history, patients from claims, from EHR. We have partnerships with vendors. We collect our own data on patients just through working with them. We have field teams that go in the home and work with patients. And we'll talk through how we use some of that data today, as well as some practices and disciplines that we think are helpful for anybody trying to make use of data effectively in healthcare.
And I'm Patrick Murda. I'm Chief Technology Officer at Realized Care. We are a digital therapeutics organization, which means we use technology such as virtual reality and mobile phones and those types of things to deliver immersive experience for folks with social anxiety, depression, opioid addiction, chronic pain, a few others in there. I lead our data science and engineering functions, and data is everything for us, right? Because the ability for these connected devices to share information with the EHRs, do real-time analytics, and make sure we're serving up the right experience that's optimal for a patient is really, really critical for us. And also being able to share that information back is super, super important. So.
All right, thank you. Panel, thanks for joining again today. So I'm excited to start the conversation. So we know in healthcare today, we still have the challenges of a lot of disparities in healthcare, access to care, and things like that. Let's set the stage for the audience here a little bit, just about what are some of the use cases when we talk about data. What does that mean? Data being data-driven outcomes and some of the technology and the way that brings that together for providers and others who are in the healthcare system to be able to use that to help understand patient access, patient outcomes. So Patrick, why don't you jump in? How about you give us a couple examples?
I will. So I'll start with, when I used to give these presentations a couple of years ago, I used to use the term inflection point. because we were on the advent of FHIR, like Dr. Rucker was saying. We had value-based care coming to being. We had willing partnerships in healthcare, which was quite unusual given our history. And we had a need to serve patients, right? The foundational stuff that we've done over the last couple of years in sharing data using standard APIs and common data sets and standard formats has been remarkable. But I would frame it up as setting the stage as we're almost on a second inflection point. Data has been, or starting to be liberated and democratized from systems that it was locked in for years and years and years, mostly from a payer perspective, but also from an EHR perspective. But the ability to take that data and join it with other information that we're obtaining, such as patient-reported outcomes, things that are being derived in real time, joining that with administrative data, X12, the classic claims and referrals and authorizations, and also the clinical data, and being able to act on that immediately using AI, like getting real-time case summaries for clinicians, or providing feedback directly to a patient in real time, is where my head is when I think about what we need to do from a data perspective. So data at rest and not being used was really cool 25 years ago. Data being used for actionable insights in real time is really needs to be now. So I'm pretty excited about it. I was really excited about the FHIR stuff. And now the fact that we have just AI that can take information from disparate sources, join it together, provide concise summaries in real time is really, really key. And I'll also add that, especially in the digital therapeutic space, I come from a payer background, so the X12 stuff and the clinical HL7B2 is part of my blood. But now that I'm in digital therapeutics, patient-reported outcomes and that type of thing, and getting that in real time, and marrying that with other information, we're seeing insights that are just remarkable. And also the ability to drive patient engagement, because that's what we've been missing for many, many years. And the ability for this data and this AI to actually motivate people to come back to the therapeutic or to go visit their doctor, whatever the case may be, is showing remarkable progress.
That's great. Don, let's keep it on the technology front for now. So with what Patrick said there, maybe expand a little bit on that from your perspective in One Up Health. Yep.
I think what Patrick said is absolutely spot on. As I look, and we've sort of spent some policy time together as well, as it turns out in history. You look at Medicare Advantage, the political heat on Medicare Advantage right now is immense, right? The MA plans, the MedPAC report from Congress this summer had that MedPAC, so this is Congress's analytic firm, this is not just somebody's opinion, has 22% more cost per capita on a risk-adjusted basis in MA. So you're going to see, I think, two things come out of that fold right back into what we're talking about. One, you're going to see all kinds of reporting requirements, because that's the first thing the government who's paying for this sort of likes to do. That's the reflexive sort of maneuver. And then I think you're going to see actual economic pressures on having tighter management of patients. And I believe that will absolutely need more than claims data. We've come a long way on inferring data from claims. X12, whole businesses, most of health services research. We're now at the point where you, to the extent that you're a payer, or pari passu, if you're a provider in an at-risk arrangement, which they're all going to be, you're going to have to be able to compute in real time on the combination of clinical and financial data. The beauty of a lot of the work that, including the work in FAST, has allowed us now to sort of have a somewhat level playing field between claims and clinical data. But anybody who's in this space is going to have to think about, what's the platform I need to do this? Because you look at STARS rating, all of those measures require some deep clinical insight if you're going to crawl your score a little bit higher than your competitors. So I think that's the dominant thing in modern plan software and design. It's very interesting, obviously, because how do you do it, and then you get into the behavior change.
Sure. Thank you.
Yeah, no, I might add sort of the clinical sort of side of it and the use cases there as well. So think about starting a new program like Sniff at Home, right? We want to send patients who would ordinarily go into a facility to get those services in the home. Making sure that we're identifying the right type of patient for that program in real time and somebody who, again, when we're doing those programs in the home, we want to make sure that the quality of those programs is the same, if not, much better than what they would be getting in a facility. So the patient identification and tracking outcomes becomes really, really important. And so it's a virtuous cycle to make sure that we are continuing to refine that approach. Another example that again, talking about behavior change, our DME company recently launched this AI tool where the tool can scan somebody's face. It's an app on the phone, right? And they will suggest the right type of CPAP to wear. And think about the number of people that you know who have a CPAP machine sitting in their closet. Right, I certainly know somebody in my family where they've been given that and it's just been sitting in the closet. But having that sort of fitting done, and then the data from that is monitored around the clock, right? So our team can come in the morning and look at real time. Was that person adherent? Was the mask fitting like it should? And we've seen our compliance rates because of all of that go from 50% to 80%, right? Which is an enormous impact, and not just to make sure that they're wearing it, but think about the downstream impacts, right? When people are not getting that, from a clinical perspective, you have impact on their heart, that they're falling asleep during the day, more accidents happening. So moving a metric like that through a very inexpensive approach to collecting data and monitoring in real time can have an enormous impact.
That's a great example, and I can relate.
Yeah.
Because I'm like that commercial, I'm part of the CPAP club or the CPAP support group or whatever. So
Yeah, okay, you are.
I'm trying to get rid of my mask. But yeah, that's a great example about how that data is important and how many ways it can affect a patient and making sure that you've got the right treatment and they're being compliant too.
Yeah.
So that's a great example. So Rohan, let's pivot because I love hearing, we heard the home health side of it, but talk a little bit about, you're in the dialysis space, value-based, and a little bit of everything. But talk a little bit from your perspective. Yeah.
Yeah, no, I think there's a lot of use cases that you can look at. The variety of data that we collect, as I mentioned, we got claims, we got EHR, we have our own internal EHR when we're working with patients. We're trying to get patients to manage their blood pressure, to manage their A1C, try to educate patients on the value of that, educate them on the value of taking ACE inhibitors and their medications on time. And I think in the process of doing that work, we collect useful information. So we collect call center, we have a call center, and we have phone conversations with patients, and we have a lot of hours of that. And what we've been able to do is use that to better be able to engage patients, to your point, Patrick, about better patient engagement by looking at factors like empathy, reading level, rate of speech, and scripting that our folks who are staffed on the call center who are talking to patients use when communicating with them. That improves patient consent rate, that improves or reduces patient no-show rate. So I think aligning to a key process and really thinking hard about the data that you collect there can pay a lot of dividends. And I mean, that's something in the technology world, we've seen that for many years. Big tech companies use that playbook. In general, the three-legged stool that we look at when we try to evaluate use cases are, do you have data, replenishable, rich, unique, differentiated? Do you have a workflow that you're impacting? It could be closing care gaps. It could be preventing readmissions for patients. Do you have a SMART goal? SMART is in specific, measurable, time-bound, that you can use to decide if it's worked or not. Sometimes I think a pitfall that people get into when they're a solution looking for a problem and they miss one or multiple of these. And so.
Yeah, no, that's good. So I told you I worked on the provider space for 30 years. So I worked for a company that had a lot of the different levels of care in healthcare. And we worked very closely with the acute care systems to try to identify where patients should go. And I just remember spending an enormous amount of time talking to customers and clients about, what are the tools that they're using, what's the data that they're using to try to determine where to place a patient at the right place at the right time. And when you're in the whole post-acute space, you've got all those different services. Even though we own those services, we too struggle within our own company to understand, like, where should that patient go? But we were also always trying to understand too of where are their gaps. How do we help close those gaps that are in care, and how disjointed that healthcare still is in the continuum. So yeah, Don.
There was a great example. We were talking in prepping over lunch that Rohan mentioned, which is, and correct me if I misunderstood it, but we were talking about how folks enter your program, and you were saying that you have claims, and the claim is for a diagnosis of some form of kidney failure or chronic kidney disease. Well, the interesting thing about that is, if you had a tight integration of clinical data and financial data, you would realize probably months to years before you had a claim for chronic kidney disease, you had an elevated creatinine. This stuff in general does not happen overnight. So by not having that integrated, you've given up years of dirt cheap prevention. So ACEs and ARBs and blood pressure control. You've given up years of dirt cheap prevention, which, by the way, would also help your star ratings, just saying, by not having the clinical measure before you have the claim. Because as a clinician, unless this is like one of the 5 things a patient has complained about, they're there for something else. Right, they're there for the diabetes. Maybe they're there for the blood pressure. Maybe they're there for, their shoulder hurts. I had one of my former colleagues at ONC text me today that he had to spend 15 minutes answering "quote unquote" inane questions from the nurse. He's about 35 years old, on his shoulder pain from weightlifting. I reminded him that might have something to do with the policies we did. But there is a lot of early data out there that people can harvest. And that example is a perfect thing where you can have a lot of life extension very inexpensively. So that brings it up. And, you need to get the clinical data, though, right? Yeah. And creatinines are everywhere. Everybody who's seen a doctor has a chem panel and a CBC. Right. So, those things are ubiquitous. Yeah,
I think to your point too, like the solution there is getting access to data, integrating the data. It's like one path. Another path that we talked about too are predictive models. Using data to say someone should have this diagnosis code. They should have this ICD-10. They're not coded with it. We need to accurately document and get them help. So there's many different ways to solve that problem, and I think the simplest one is what you've described, which is just harmonization of data. Yeah.
Well, folks may know with payers, under the Cures Act, so the 21st Century Cures Act, there's a bulk FHIR API requirement on EHRs. So if you write that into your network contract, you are able to get a whole set of data, I will say automatically coded in FHIR that you can then import into whatever data architecture you're doing for clinical. So that is available as we speak today. That's not mañana.
Anything you want to add to that?
I just echo what Dr. Rucker is saying is, and if you're negotiating value-based contracts, if you're overlooking that, you're overlooking something really, really important. Because getting data early and fast, and it's not black magic to bring clinical and administrative data together. Matter of fact, payers have been doing this. I worked at Humana for 25 years, so I know this. For many, many years, if you've got the data, you can predict these things well in advance. And to give credit to payers, they want to predict these things because it certainly helps patients with better outcomes and better experiences, and it helps their overall ecosystem. So yeah, I think that's good.
That's positive.
Yeah.
All right, let's jump to just talking about what the future looks like. in this space, and a little bit more about that. We've already touched on a little bit of that already, but and of course, you hear we know AI like it's in our lives. It's come very quickly. We're also trying to figure out, is this AI or is it not AI? But maybe we should frame up or try to frame up kind of how you see AI playing a role in data-driven outcomes and being able to manage patient populations, and kind of what you think we can expect in the future with how that plays a role in this.
Can I start?
Yes.
Because it is really interesting. If you hear the conversation we're having, yes, we mentioned AI a little bit, but a lot of it is about the basic blocking and tackling of having the right information that's integrated in the right ways to be able to say, hey, this person's creatinine is headed in the wrong direction, and maybe they need to be on this medication that would be helpful. That is not some crazy out there futuristic solution that's requiring a lot of investment in novel algorithms. That is really making sure that we are doing the basic blocking and tackling, which is some of the most unglamorous work, right, around making sure that we have the right connections. And frankly, if you don't have those connections in place, then moving to the AI solutions it would not be the place I would make the investment. So I think there's a lot of value that is still left on the table because we haven't done that work.
Sure.
And even in back to what Patrick was saying, I mean, one of the reasons that our previous employer has had the success it has had from a stars rating perspective is because we were, I think, the first pair to integrate into Epic and to be extracting that information. And that was a very, very important component. Again, not something that requires crazy investment, but that blocking and tackling that over time can yield to real value. I do think there's a role for AI. I think from a productivity perspective, especially to make sure that we are removing the things that are very burdensome for our clinicians, from a documentation and perspective, and allowing people to work to the top of their license. So I certainly think that we need to do that work as well, but we should not forget within the hype cycle that we're in right now that there is some real value that we haven't taken hold of yet.
Sure, good point.
I'll get off my soapbox.
No, that's okay. It's an important one. It's important. Anything, Rohan, to add?
No, I
from
agree
your
with Mona
perspective?
totally. I mean, I think getting the basics right is really important, and there's for organizations that are a bit earlier on, like getting your data strategy right. If you don't have a lot of data, you want to collect it. Maybe there's a way you can buy it in a PHI sensitive way. There's a way you can collect it through your apps or through other channels. For the ones that are collecting a lot of data and have a lot of data, doing some basic things like go catalog all of your data sources in your data warehouse or your data lake, and catalog all the different flavors of the key performance indicators and metrics that you use, and just make a decision on what should be used in which context. You'd be surprised how much value you get out of that. There's not a lot of technology you need, but it's very, very useful. Further along, you can start to do some of the more advanced data modeling, semantic model design, as it's called, building reporting cubes. That foundational part is extremely valuable, and to Mona's point, it has not been unlocked at many organizations. So I want to echo that. That being said, there is opportunity for AI, and the key is to just have discipline with how you apply it. As long as you are developing with your end users and you're working closely to make sure that it'll get adopted and it's not just a prototype, but something that you can use, it goes a long way.
Yeah, I think, when you look at the sort of the near-term future, you have to honestly, I mean, cloud is sort of a buzzword too, but you really have to, the beauty of the cloud, I think when it first came, it was just storage. I moved my storage headache off premise type of thing. The real power of the cloud is that you can put all kinds of bits and pieces of computing into the data stores you have. you can uncouple. That's not the case typically with the classic enterprise data warehouse and Tableau and sort of pre-structured queries that most people are running. You want a nimble environment where you can use your data for many purposes without a lot of additional reformatting. That's what FHIR gets you. Patrick led the FHIR at Scale task force back in the day on this stuff. But you have to have the nimbleness of that. And sort of what are the things that you want to have? You want to be able to have all kinds of different applications, whether it's something that is interesting like the CPAP fit application, right? You're not going to build a SQL server to do that, right? You're just not. Whether it is APIs, however you communicate out, whether it is real-time communications on smartphones. I mean, we live in a smartphone world. So if you have a platform where you can't do real-time analytics and communications of those tiny behavioral nudges that really move the ball, you're not going to be there. So the choice of platform and platform architecture, I would throw out to folks, and Rohan mentioned it in its two pieces, but the classic way that people who do this in the rest of the world, so the non-healthcare world, is sort of what's called a lakehouse architecture, right? So you essentially are doing, this is a super buzzword, but you're essentially having the plasticity of using metadata and metadata on metadata to give you extraordinary flexibility. So you don't have to figure out the individual fields for every business use case. You have those cataloged and are running them. And the beauty of computers now and indexing schemes is you can finally do that. This is something we've never, ever had before. But computing power is now such that you can do that. So that's, I think, the platform architecture that gets you these things and then all the different steps that come along.
Gotcha. Patrick,
Yep.
expand on that?
That was great conversation. I'm going to try to bring it all together, right?
Let's do it.
So totally agree with what Mona said. It's foundational. It has to be table stakes for interoperability and integration and all that type of stuff. But let's just bear with me for a second, dream with me for a second. When that is there, the power of what AI can do, especially in patient engagement, is remarkable. So at my and I was a doubter, right, a year and a half ago when we first started using user experience design and that type of thing, in which we were using data that we had, conversational AI via SMS, mobile devices, having AI engage with folks with a persona and a personality that the person felt comfortable with, they chose it, and being able to elicit information. So you've got claims information, you've got clinical data, and now you're actually getting information from patients and turning that back into the models and following up and asking them how they did over the weekend. And hey, you said you were going to do a walk around the block, how'd that go? And that type of thing. It's shown remarkable progress as it relates to bringing patients actually into the ecosystem. I think that's what we've been missing for many, many years. And then to kind of double click on what Dr. Rucker said is for the technology people in the room, or even if you're not technology people, go knock them in the head when you get back to your office, is that in a cloud infrastructure, things that took us months and years to build 2 years ago in the cloud are point and click. Deploy this model. Deploy this RAG model. Here's a single document, train the AI. You can do things in hours that and I've been doing this for a while, that used to take us a long, long, long time. So the power of what we can do from a platform perspective is just remarkable, as Dr. Rucker said. I've got some other notes here that are kind of jumbled together. So I think I got the most ones. Blocking and tackling, the power of the cloud, and for me the most exciting thing is, and I'm an engineer, so this is weird, it's patient engagement. Seeing patient engage with the model,
Yes.
with conversational AI, and actually being able to tune our experience to what they actually need and see better patient-related outcomes is just phenomenal for me. So.
Yeah, good. Thanks, Patrick. Let's just keep, Rohan, I'll kick it back to you. We'll just do some closing remarks, and then we'll hand it to the audience for some questions. So we'll let each of you kind of wrap up with some closing remarks.
Yeah, no, I mean, I think the future is really bright, and there's not enough time to do everything. So thinking hard about like your organization's business goals and trying to prioritize effectively is helpful. It helps I think sometimes to communicate the value of making technology investments and to use some of the the cloud managed services that Don and Patrick talked about. They can be a little pricey. Sometimes it requires a little bit of value prop discussion. So it's a worthwhile investment, and things will continue to get cheaper and better over time. So keep an eye on it. Read the literature. We spend time reading papers and just seeing what else is out there. That gives you a little more confidence if you want to try an experiment. Work out an experimental framework where you can pilot out new use cases. So 80-90% of the time it might be business as usual, but maybe there's a very, very interesting emerging opportunity. So that's one perspective you can take.
Thank you. Mo?
Yeah, I think I might take a slightly different perspective on, I think the partnership between the business side and the analytics side is just so important, right? Oftentimes, the analytics team kind of goes off and you're like, I need this model for identifying this thing, and then they come back and then you deploy it, and then a year later you're like, well, this didn't quite identify what I was actually looking for. And I think it is just really important to say, what am I really trying to do? You can only get data-driven improvement in outcomes if the collaboration is there, if the analytics folks are understanding the business problem, if you're understanding from the business side what the variables are that they have access to, and really kind of doing that back and forth, and that partnership then just sort of it's additive over time because you're both sort of getting an understanding of the problem that you're trying to solve. And for me, I would say both in my current role and in my previous organization, that partnership, I can't get an ROI on a program I'm deploying if my analytics team is not partnering with me to identify the right people, right? There's basic things, but I think even if you're not if you're not a data or a tech person, you have to have you have to have the interest and lean in on that partnership. And I've seen from my analytics colleagues a desire to really understand the business side of it and the business problem. So I just think that's really, really important. We don't talk about it enough, and that collaboration.
That's a great point. Great point. Yeah, I think in my former life, what I did before, we were always trying to make sure we had the clinicians in the middle of that too.
Yeah.
But again, always thinking about the patient being the center of that, whatever it is that you're trying to accomplish with analytics, right? So yeah, that's a good point. Don?
Yeah, I think the world is going to be driven by APIs and business strategies that combine APIs. That's the point, the point and click type of approach. So I think as you're looking at your things, you're sort of going to have to pay at least some attention to tech as much as, for many of us. I mean, I did a whole residency before it even dawned on me to take a computer science course. So, but I think we're all going to have to, in our own way, get up to speed on that. I think you have to think about APIs. I think you have to think about not just interoperability, which is, has been a buzzword for decades. You're going to have to think about computable interoperability. And this battle is actually raging right now. We're, a battle between TEFCA, which is an older model of document exchange and brokers that is not really computable, and RESTful and FHIR and JSON, which is the computing that we use literally millions of messages a day on your cell phone. So, and that allows you to compose all of these types of interfaces and activities. So I think you're going to have to think very clearly about what your API strategy is, what brokers. This stuff does get expensive. Cloud can get very expensive very rapidly. So you're going to have to think about how I have low friction, high potential IT environments. The good news is there are extraordinary ways to totally blow away the competition today. The bad news is you got to think about it a little bit.
Yeah, good point. Okay, well, we'll wrap up now and just take some questions from the audience. So Elizabeth, all right, we've got one here in the back.
Dr. Rucker, I love
Please call me Don.
Oh, Don. It's nice to meet you. I'm a big fan of OneUp Health's APIs. I query them all the time. The capability statements are They're great. I heard the word metadata repeated like 4 or 5 times, like from all of the participants. And I just wanted to see if you guys could talk a little bit more about, discoverability of the right data and how to find the right sources.
Yeah, I think the specific concept of metadata I was referring to are lakehouse architects where you have manifests sitting on top. So let me just say a word about the evolution of the data stores that the metadata is referring to. Historically, well, if you're as old as me, my data computer science course in databases was hierarchical databases, pre-SQL, but that's my problem. That's not your problem. And then we sort of had SQL for a long time, super powerful, has dominated the world, very mathematical, very tight, nothing lost type of stuff. And then in the aughts, we started looking at NoSQL when you had Facebook and Twitter, and people who didn't need to have the rigid data of like your bank account. They just wanted to get some type of transaction. And then you had data lakes, which we're spending a lot of time, a lot of compute cycles on computing. Let's put the computing off until later. And then people said, oh, well, then we can't find the data. And so now where I think the modern tech industry is going is sort of a concept of lakehouse, which is one of those combination words of data warehouse, sort of classic organization, and data lake, which is just put it there and organize it after the fact. The metadata comes on how you index all of that stuff and how you version it, right? All of these data standards we talk about, we talk about FHIR, God knows I'm guilty of that ad nauseum, but they all have versions, right? Whether it's X12, I mean, maybe not as rapidly there, but all of these things have versions. And so the metadata of the manifests or things like that allows you to do it. You don't have to use exactly that architecture, but I think you have to think about what is my control plane on indexing the data. That's what you have to think about. And what are the APIs to get at that data quickly? Hopefully that gives you a little sense of what we're talking about with metadata.
And Ron, just add a little more color to that, because as we all know, that metadata can sometimes be very good. It sometimes is a little more than a joke, right? And I think that's what you're driving at. And what Don mentioned is certainly a good way to look at that. But one of the other things that we've been able to do with AI is to have it look directly at the data with having knowledge of fire resources and HL7 and that type of thing, but not telling it specifically what it was looking at and trying to derive intent. And the model would come back and say, this is referencing this, or this is, although it's not metadated as an ICD-10 code, it's clearly an ICD-10 code in a comment section or something like that. So having AI review the data and make recommendations on mapping and how you segment and index it has been really fruitful for us as well.
Yeah, I had one thing there. And I loved your talk earlier today, by the way, just as a side note. You sort of have to decide, is this data, and I'm going to use a total nerdy term, ACID, which is basically, how tightly is this data controlled? It's an acronym. Versus, is it loose, a little bit looser, where I can have some definable, measurable rate with AI calculations. That, by the way, is going to come up for all the EHR data that doesn't have clear fire standards, isn't used as CDI, and that is sort of out in the wild. So it's going to be both.
Very good. Aaron.
Talked a lot about the magic of integration of clinical data. Oh, can everybody hear me?
Yeah. Go ahead.
Well, when you use the mic.
And you referenced the 21st Century Care Act and the requirements of major EMR companies, Epic and Cerner, to release that data. Are you seeing that at scale? Because what that mandate is, what is actually happening in reality, there's a large gap. The second piece is, if so much of that data is in the unstructured sources, which more and more applications of large language models, applications of AI shows that it can get at it. How do you, what's your point of view of combining, and it is blocking and tackling, but combining that to unlock the magic of clinical data
So the Cures Act, you're absolutely right. It is ultimately is a mix of structured and unstructured data. I would say the maybe enforced willingness of the participants you mentioned to share the data has radically increased. Is it where it could be? I'll leave that for you to decide. But there are, Congress put in information block, and again, all of this goes back into President Obama's administration, right? The Cures Act was passed before President Trump. This was 2016, and it was passed almost unanimously in Congress. So I think there's a public will to not have this stuff hidden from us. And I think people are coming up to speed. The question you're stating on how you blend structured and unstructured data is, I think, a great computer science question, and that is where some of the AI tools that Patrick mentioned are probably going to be at their prime.
Thank you.
All right. Any
You
other
can
questions?
do one more.
Yeah, I could do one more. Got just a couple minutes. Someone has a burning question out there. Nope, that's it. Okay. I want to thank the panelists for your time today. That was very insightful. I really appreciate it. So thanks for coming.
Thank you.
Thank you.